Artificial intelligence is changing the way so many industries operate, and healthcare, which is more than 17% of the U.S. GDP, could show significant change in patient care as a result. Joining us right now to talk about this.
For decades, the front desk has been the nervous system of this world. Schedulers, receptionists, and billing clerks learn to read faces before words, to hear insurance plans in the tone of a voice, to manage the slow panic of a crowded waiting room with a keyboard and a smile. In many American hospitals, that job is now sharing the desk with a new arrival. Silent, tireless, and built from code. Administrative work in the United States health system has always been large enough to feel like a second industry layered on top of medicine itself. Studies published in JAMA have estimated that administrative expenses account for roughly 15 to 25% of national healthcare spending, a share far higher than in many peer nations. Analyses from the Commonwealth Fund suggest that administrative complexity alone explains around 30% of excess United States health spending, driven by coding rules, eligibility checks, and endless back and forth between providers and insurers. One recent study of the health workforce found that in clinical settings in the private sector, nearly 1/4 of personnel hold administrative roles rather than direct clinical jobs. The modern American hospital is not only an intensive care unit and an operating theatre, it is also a factory for forms. That factory has become a prime target for automation. Consulting work from McKinsey and other groups has argued that automating administrative tasks and using analytics could strip away hundreds of billions of dollars in spending each year, largely in back-office work. The American Hospital Association has warned that administrative costs, including labour tied to billing, prior authorization, and insurer policies, now consume more than 40% of hospital expenses in some systems. The financial pressure is not abstract. Hospitals have cut jobs and services after the pandemic, reporting that margins are thin, labour is expensive, and recruitment cannot keep up with demand. In that environment, any technology that promises to reduce keystrokes looks less like a gadget and more like a survival plan. The first place many patients now meet that plan is not at the desk at all, but on a phone. Leading systems such as Cleveland Clinic, Mayo Clinic, and Mount Sinai have built conversational artificial intelligence into their patient portals and contact centres. These tools book, change, and cancel appointments at any hour, send reminders, and route simple questions without human staff. At Cleveland Clinic, an artificial intelligence virtual assistant serves as a guide inside telehealth platforms and helps manage appointment flow, while robotic process automation projects allow staff to script away repetitive steps that once filled a day. For a scheduler who once spent hours on the phone, the first noticeable change is the silence. Fewer rings, shorter queues, more calls that arrive already filtered and formatted by a machine. Outside the hospital, the same transformation is taking place in independent clinics and physician practices. Appointment booking companies such as ZocDoc have deployed automated assistants that handle the entire scheduling conversation in natural language, reporting that a large majority of bookings can be completed without human intervention. Contact center vendors describe hospital clients where voice agents and chatbots now resolve most routine interactions, from confirming appointments to updating insurance information, while human agents handle only the exceptions. The job that once meant answering every call has shifted towards supervising software and stepping in when that software hesitates or fails. In that shift, the work itself is being broken apart. The traditional front desk role bundled several skills into a single position. Answering phones, reading schedules, interpreting authorization rules, calming anxious families, deciphering a physician's handwriting. Artificial intelligence systems unbundle those tasks. Scheduling algorithms scan provider calendars and patient preferences to propose optimal slots. Natural language models capture insurance details and verify benefits in real time through payer portals. Chatbots triage simple questions about directions, parking, or office hours. What remains for many human staff is the narrow band of work that machines struggle with. Angry callers, confusing insurance products, or situations where a script breaks and a person must quietly repair the damage. Behind the scenes, the same logic is being applied to the flow of bodies through wards and emergency departments. Research groups in Europe and the United States have developed artificial intelligence models that forecast emergency department crowding hours in advance by analysing historical arrival patterns, weather, and local events. A recent study of emergency department staffing used machine learning to predict daily visit volumes and optimise shift schedules, reducing mismatches between staff levels and patient demand. At Cleveland Clinic, a partnership with Palantir Technologies created a virtual command centre, a kind of operational radar screen that tracks bed availability, forecast capacity, and ties staffing to real-time demand across a large network of facilities. The job of the human bed manager, once built on intuition, hallway conversations, and experience, now unfolds over dashboards that color-code urgency and suggest moves before a human has time to worry. Even small details of this operational layer are being optimized. Artificial intelligence systems sift through records of missed appointments and learn which patients are likely to be no-shows, adjusting reminder strategies to reduce that risk. Some vendors claim reductions in missed appointments of roughly 1/4 to 1/3, alongside large cuts in staff time spent on manual reminder calls. For the receptionist who once spent the last hour of the day calling tomorrow's patients, the task list shrinks as automated messages go out on their own. The technology does not arrive as a pink slip. It arrives as a quiet line in a meeting. The reminders are now handled by the system. Nowhere is the impact on administrative work more visible than in revenue cycle management, the complicated machinery that turns care into claims and claims into cash. McKinsey has estimated that automation and analytics could eliminate hundreds of billions in administrative spending across United States healthcare, much of it in billing and insurance operations. The American Hospital Association has highlighted artificial intelligence as a key tool for improving the revenue cycle, particularly in coding, denials management, and prior authorization. Industry case studies report that machine learning models now scan claims before they are submitted, correct coding errors, and flag documentation gaps, cutting claims processing times by up to half in some implementations. Coding specialists and billing clerks remain, but much of their effort is now filtered through software that decides which cases require human attention. On the insurer side, the same automation has moved into more controversial territory. A wave of reporting and legal complaints has alleged that major insurers, including United Healthcare, Humana, and Cigna, have used algorithmic tools to speed up utilization review and deny claims for post-acute or rehabilitative care. One investigation described internal pressure at an insurer to adhere to automated benchmarks when deciding when to end coverage for Medicare Advantage rehabilitation, raising concern that software was quietly shaping the length of a patient's stay. The American Medical Association has warned that artificial intelligence tools used in prior authorization can increase denials and administrative burdens, despite public commitments from insurers to reduce red tape. Physicians report that even when requirements are nominally streamlined, the volume of authorizations and the complexity of automated systems keep workloads high. Public scrutiny has forced a partial response. In the summer of 2025, more than 50 health plans, including United Healthcare, Aetna, Cigna, Elevance, Kaiser Permanente, and major Blue Cross Blue Shield carriers, signed a pledge coordinated by America's health insurance plans and the Blue Cross Blue Shield Association to simplify pre-treatment reviews. The commitments include reducing the number of services that require prior authorization and responding in real time to at least 4 out of 5 electronic requests with complete documentation by early 2027. Trade groups portray this as modernization, a move away from fax machines and manual phone calls towards standardized electronic exchanges powered by automated rules. Critics see an arms race, in which insurers deploy artificial intelligence to screen care more quickly, while providers scramble to use their own tools to navigate, predict, and appeal those decisions. That arms race has begun to reshape the work of prior authorization inside hospitals and clinics. In many organizations, dedicated teams, once called insurers, waited on hold and entered answers into proprietary portals. Today, artificial intelligence agents can log into those portals automatically, populate forms based on structured data from the electronic health record, and track the status of requests at scale. Some systems even experiment with generative models, that draft appeal letters against denials, mirroring the language and structure that past experience suggests will succeed. The people whose names once appeared on those appeals may still sit in the office, but their daily work consists of supervising queues, checking edge cases, and intervening only when algorithms disagree or a denial touches a particularly high-risk patient. The psychological effect on staff is subtle. Administrative workers in hospitals have long been used to change. New billing codes, new regulations, new software updates rolled out overnight. Artificial intelligence feels different, not because it appears as a robot, but because of where it sits. It occupies tasks that once defined an entry-level career path into healthcare. A receptionist position was often a first step into the system, a chance to learn how insurance works, how departments interact, how patients move through care. As automated agents take over the simplest interactions, many entry points narrow. Job postings tilt toward roles that combine administrative knowledge with analytics, information technology, or compliance. The person at the desk is expected to understand not only the schedule, but the system that built it. Some organizations have tried to turn that transformation into an internal bargain. Cleveland Clinic's Robotic Process Automation program encourages staff to propose and design automations, offering training so that nurses, finance clerks, and facilities workers can build scripts that remove repetitive tasks from their own days. It is an acknowledgement that those closest to the work often know best what should be automated. At the same time, each successful automation quietly proves that portions of the job can be done without a human hand. The more efficient the process becomes, the easier it is for executives to imagine doing it with fewer people. For the front desk worker, the transformation can be felt in the pace of the day. Calls that do reach the desk are more complex, often coming from older patients who struggle with portals, or from families frustrated after interacting with a bot. Walk-ins may arrive, having already navigated several layers of digital triage. The receptionist's role shifts from gatekeeper to fixer, the person who solves the problems technology cannot anticipate. It is a role that demands more emotional labor and more system knowledge, but not always higher pay. In some settings, call centers that once hired large cohorts of entry-level staff now rely on smaller teams with higher technical skills, supported by artificial intelligence agents that handle routine traffic. In billing departments, the change is similarly uneven. Staff who specialize in complex cases, appeals, or financial counseling for patients with multiple coverage sources remain in demand. Routine charge entry, eligibility checks, and status updates on clean claims are increasingly automated. When financial pressure grows, leadership can point to automation metrics and justify leaving vacant positions unfilled. Job cuts are not always announced as technology layoffs. They appear as hiring freezes, attrition, or reorganizations in which certain functions are centralized into shared service centers that lean heavily on artificial intelligence and robotic process automation. Yet the system's reliance on administrative labor has not vanished. Administrative occupations still make up a large share of the health workforce, and administrative waste continues to consume a substantial portion of national health spending. The promise of automation is efficiency, but the reality is a moving target. As new tools simplify one set of tasks, new regulatory requirements, new insurance products, and new digital services introduce fresh layers of complexity. The work changes form more than it disappears. From a distance, the rise of artificial intelligence in hospital administration can look like an inevitable correction. A system that spends vast sums on billing and insurance processes is being forced, by cost and technology, to streamline. From closer range, in the lobby and the back office, the shift unfolds as a rearrangement of human lives. The person at the front desk, the scheduler in a windowless room, the billing specialist reading remittance advice lines have built careers out of making a difficult system workable. Now they watch as parts of that system begin to treat their own jobs as inefficiencies to be managed. Patients may notice cleaner portals, shorter waits on the phone, and faster answers on coverage decisions. They may also find that when something goes wrong, reaching a human requires persistence, and that the human who finally answers is responsible for more work than before. The quiet spread of artificial intelligence through scheduling, billing, prior authorization, and throughput is not a story of machines suddenly appearing in exam rooms. It is a story of software slowly disassembling the administrative scaffolding on which hospitals have long rested. In that sense, the hospital lobby at dawn has changed in a way that is easy to miss. The lights still hum, the doors still open, patients still approach the desk and give their names. But much of the work of arranging, approving, and paying for their care now takes place in servers and models far from the waiting room. The people who once did that work by hand remain present, though often in smaller numbers, and their roles are being redefined by a set of tools that regard their old tasks as patterns in data. The transformation of hospital administrative jobs by artificial intelligence is not a sudden event. It is a slow erosion, carried out form by form, call by call, authorization by authorization, until the shape of work in American healthcare no longer resembles what it once was.